Arthroscopic or inside posterior cruciate ligament avulsion fracture suture fixation with double tunnel pull-out and internal brace augmentation using transseptal approach. Preoperative X-rays, CT scan, and MRI are shown. A standard diagnostic arthroscopy is performed. A posteromedial portal is obtained via transnotch visualization. A posterolateral portal is obtained in similar fashion. Maintaining the knee constantly flexed at 90 degrees, an arthroscopic trocar is introduced in the posterolateral portal and advanced towards the posterior septum under direct arthroscopic visualization. The camera is switched in the posteromedial portal. The transseptal portal is developed working with the shaver from the posterolateral portal in a back-and-forth modality. The shaver is directed on the posterior margin of the tibia and used as blunt dissector to detach the posterior septal fibers and identify the remaining fibers to be removed. The dissection is carried out slightly distal to the PCL footprint to ensure correct placement of the transtibial tunnels. The PCL footprint is identified and prepared for the fragments reduction and fixation. The camera is switched in the posterolateral portal, and the PCL guide handle is used to drill two 3 mm transtibial tunnels at the medial and lateral margin of the PCL footprint with the aid of a cannulated reamer. Two suture shuttles are placed in the tunnels with the aid of an itinal loop passer. A 45 degrees angulated suture hook is used to obtain an intrasubstant PCL stitch with a 1.5 mm high-strength suture ribbon and the aid of a suture shuttle. The tips of the ribbon are retrieved from the posterolateral and posteromedial portal, respectively. The camera is switched in the infrapatellar lateral portal. The tip of a high-strength suture tape is passed in the posterior compartment of the knee, passing via intercruciate, and retrieved from the posteromedial portal. The second tip of the suture tape is passed in the posterior compartment of the knee, passing on the medial side of the PCL, thus embracing the ligament remnant. The second tip of the suture tape is retrieved from the posterolateral portal, producing a cross-tie configuration of the suture tape on the PCL. Visualizing from the infrapatellar lateral portal with the aid of a femoral PCL guide handle and a 4 mm cannulated reamer, a tunnel is drilled at the center of the femoral PCL footprint. A suture shuttle is retrieved from the posterolateral portal in the anterior compartment of the knee. A high-strength suture tape is loaded onto a loop-adjustable cortical fixation device, configuring the internal brace ligament augmentation. The button is flipped on the medial femur cortex under direct arthroscopic visualization. The previously positioned suture shuttle is used to retrieve the internal brace in the posterolateral portal. The sutures in the posterolateral portal and internal brace ligament augmentation are now retrieved in the lateral transtibial tunnel. The same procedure is performed by retrieving the posteromedial portal sutures in the medial transtibial tunnel. The final configuration of the fracture fixation is characterized by the transverse ribbon suture reducing the fracture, the cross-tie suture tape compressing the avulsed fragment, and the internal brace ligament augmentation system protecting the suture fixation. Optimal reduction and stable fixation can be seen. Maintaining the knee at 90 degrees of flexion, a cortical button is used to secure the sutures on the anterior tibial cortex with sliding knots. Final postoperative X-rays are shown.